can go on with the Bible. Okay, so your time starts now.
Should I start right away? All right.
Yes.
Okay. Okay. So I will enter the room and sanitize my hand. I'll read my instructions and I will introduce myself to the patient. And that my name is Dr. Rashid, and I'm one of the doctors here, and I'm going to examine you. If will it be fine for you?
Okay.
So if you have pain anywhere, please do let me know. I'll be gentle. I'll just take 3 steps back, and I'll take a full like a good view and look of the patient, and around the patient I can see that he's having a walking aid by the side, and he has a fixed posture of his left hand. Then I will
Yes.
go towards him, and then I will ask, first of all, I'll gently try to take the tone of the patient from both sides, and from the wrist and the elbow, while asking the patient to be nice and relax his hands. And then I will take the check the powers in both of the hands
I'll try to.
from the 3 sides, like from the shoulders, to check the. Can you please push? Can you please cross your arms over his shoulders and then push me up, and do not push. Do not push me. I'll push you down. Do not let me. And then from down, I'll ask him to push me down, and then I will from the. Can you please make this boxes posture, and then I'll ask him to please push me out and push me in from both sides. I can see that he can, if there is a I can help him with his left hand to check, and then from the wrist also. Can you please stretch out your hands and close your eyes to see for the pronator drift, and then I will ask the patient, I will check the reflexes now from the wrist, elbow, and triceps. Then I will check the I will now check the disc diadoc. I'll ask the patient, can you please do the repeated movements of your from your left and right hand both? And then I will ask the patient to do the finger nose test for me. So by these, and then I will also like to check the sensations. I will start with the pinprick, and then this is this sharp. I will just touch the pin of the pin to the head of the pin to the sternum. I will put it at different points of your arms. Do let me know if it feels the same at both sides. So I'll put at different dermatomes of both sides of the patient, and then ask him that if he feels the same in both of the sides. Then I will do the power check of the from both of the fingers. Can you please grip my fingers from both hands? And then I will ask the patient to spread out the fingers, and I will press from the little finger and from the thumb to do not push. I'll push him in, and I'll ask him to resist me if he can. And then I will do the, can you please put your thumb up? I will push it down. Do not let me push it down. And then I will do the adduction similarly from both hands. If he's
2 minutes are left,
able to
doctor.
Okay. Okay, and then I will like to see the proprioception. This is the tuning fork, and I like to see the this is start and this is the stop. And I will put him at different bony prominences and will check if he can feel the vibration. I would yeah, so this is the vibration, and I would like to complete my examination by checking the lower limbs, cranial nerve examination, gait, and so this is how I want to complete my examination. And cerebellum I have already checked, but I would also like to check his pulse and cardiovascular examination.
Yes. So you've covered the steps well, and when we are verbalizing it, it takes a shorter time. But when we are doing it in the exam, it will take its time of 6 minutes. So I'm just going to revise the points that have to be covered within the examination, and that is upper limb, pronator drift. Start with that. Plus minus, you can check the Hoffman's sign.
Oh,
Then tone, power, reflexes. I'm just going to mute the. Okay. All right, I will start again. That when we are examining the upper limb, so we will be covering pronator drift, plus minus Hoffman sign, tone, power, reflexes, coordination, and then sensations. In sensations, we are checking the pinprick, soft touch, vibration, and proprioception. So we have got numerous YouTube videos where we can review the steps of examination. Then you can practice it on a colleague, or if you're going to the wards, you can do it on a patient's on bedside. This will build up your confidence. You will be in a flow to examine the patient so that you don't miss the steps during the exam because you have got marks for the examination technique. And once we have finished it, then you can verbalize that I would like to complete my examination by checking this patient's lower limb and cranial nerves with some bedside examination. If you have time, you can also check the radial pulse for irregular rhythm, heart sounds for cardiac murmurs, neck auscultation for a carotid bruit, and you can also ask for blood pressure and urine dipstick. Plus, you can mention that I would also like to check the visual fields for homonymous hemianopia and speech assessment. Now, I'm going to explain it one-to-one after we are done with this description. So when you enter this scenario, you can find a patient who has got a flexed posture of the affected side of your upper limb. If you see this image, then it is the left hand that is bent. I'm sorry, I'm just going to please make sure that you are muted during the meeting. Okay. So, and if you see the lower limb, if it is affected, it will be externally rotated. So this is the appearance of a patient who has suffered a stroke. Plus, you will give a look on the face. If it's right or left side is showing a weakness. So we will also come to that. Let's start with the differential diagnosis. So I'm going to ask Dr. Hafsa as we are rolling on to the Viva questions. And once we have finished it, then I'm going to talk about facial weakness and speech assessment in detail. So Dr. Hafsa, what will be your differential diagnosis for this case? But first you can present it. What are your findings? And then give the differential diagnosis.
all right. Though I did not have had any positive signs, but I would try to revise all of the steps I've done.
Yes, so I will give you the
On
positive findings. When
yeah.
you were examining this patient, you found that there is your findings on the left side. You could see that the hand is bent. So there is a flexed posture of the upper limb with the increased tone. I'm sorry. Power is reduced to 3/5. The reflexes are brisk, and the coordination could not be checked on the right side due to weakness, but it is normal on the left side with the
Right
rest
side.
of the signs. Yes. Sorry, left side. Yes, this is the left for this patient. And the sensations are it can be affected or it can be impaired. So you can say that it can be affected in modalities of soft touch and pinprick. So now you can present your findings.
Okay, on examination of this gentleman, I could notice that the patient was having was having a walking aid beside him. He has a flexed posture and an externally rotated right ankle, and left ankle. And on examination, I found out that the patient has the upper motor neuron signs of lesion in the form of hypertonia, hyperreflexia. The power was reduced, that was 3/5 on the left side, and the coordination I was not able to elicit because of the weakness. Sensations were affected on the left side in the form of like pinprick and soft touch was affected on the left side. Apart from this, I could not. So sorry. Hello.
Yes.
Yeah. So apart from this, I could not appreciate any. I would like to complete my examination by doing the lower limbs, cerebellum, back, and gait and speech assessment for this patient. In view of these examination I've done, the summary of this would be the patient is suffering from left-sided hemispastic hemiplegia for differential diagnosis.
Okay. So I would just revise the presentation for the rest of the candidates, and you've done well. So we can uh, just tell the examiner that I performed the neurological examination of this patient, which has shown the following signs. If I see on general inspection, there is internal rotation of the right hand with externally rotated ankles on the left side. Plus, I can see walking aid on the bedside. So this is your impression of the case. The motor examination shows signs of upper motor neuron weakness on the left side, evidenced by hypertonia, hyperreflexia with reduced power. Coordination could not be checked due to weakness on this side, but I could not find any signs on the right side, which appears to be normal. The sensations are affected in the modalities of soft touch and pinprick in the distal part of the arm, or it could be the whole side. It is variable, which depends on the case. If I put my findings together, it is likely a case of left-sided hemiparesis. I would like to present the differential diagnosis for it. Now I can ask you, what is the additional examination that you want to perform for this patient in view of the bedside tests? So then you can mention
the bedside test, I can ask for the
yes.
urine dipstick for
Mm-hmm.
his blood sugars, and then
Mm-hmm.
I can also ask for his pulse oximetry, oxygen
Mm-hmm.
saturation.
Mm-hmm.
I can also do the fundoscopy or
Mm-hmm.
a 12-hour ECG.
Mm-hmm.
And so I think this is coming
Yes, so,
in.
yes, it
Right.
was good points. So you can say radial pulse. In fact, as I just mentioned, that if you have time, after finishing the examination of the CNS or your command, then you can also check it after taking the examiner's permission. So that could be radial pulse. We are checking it for irregular rhythm. That would be a sign of atrial fibrillation, as this
Yes.
is a risk factor for an intracardiac thrombus that can throw an embolus into the brain, leading to a stroke. So, second would be heart sounds. We are checking for a murmur. That is a sign of a valve defect, and that could also be a cause of a clot within the heart chambers by causing irregular rhythm. Third, neck auscultation. We are checking for a carotid bruit, as an atherosclerotic plaque within the neck pulses can also be a source of an embolus. Fourth, blood pressure. Is if this patient has got hypertension, it's one of the risk factors for a cerebrovascular accident. And urine dipstick. Fifth, we are checking for blood sugars. If it is high, then it's also a risk factor for stroke. And yes, vasculitis, somebody just mentioned it in the chat box that vasculitis can also cause narrowing of
Yeah,
the
that can be done as a
cerebral
part of the
process.
underlying cause of the stroke.
Exactly. We can mention it in investigations as well.
Investigations. Yes.
Okay, I'm just going to take a 5 minutes break if it's okay. I'm sorry for the interruption.
It's okay, doctor.
Hello, Hafsa. Are you there, Dr. Hafsa?
Yes, sir. Yes, sir. Yes, sir.
So can you tell me how you will localize the lesion in case of spastic neuroparalysis? Stroke?
Yes, sir. Localize if it will be the like in this patient, it is this uncrossed lesion. So it's the same site. So it is most likely the lesion is in the above the pons, sir. It is internal capsule.
So I'm sorry for the interruption in the
Okay,
session.
okay.
I'm
So
back
now,
in the class.
okay.
Yes, I was just coming towards it.
Okay.
So first,
Javiria, you can continue now. Okay.
thank you, sir. So I also want to ask about the differential diagnosis now, but we were explaining why are we checking the bedside examination if we see a case of stroke. If it is upper limb or lower limb, then we must check or mention it at the end of the examination if it is a case of right or left hemiplegia or hemiparesis. Okay, radial pulse, heart
Yes.
sounds, neck pulsations, blood pressure, urine dipstick. And yes, we should mention about fundoscopy because it can show retinopathy due to hypertension or diabetes that are the risk factors for a stroke. And when we are coming to the face, here we've got very important signs if it's a case of stroke. So, Dr. Hafsa, do you want to tell about the signs or should I go on to explain it first?
Signs of what, sir? What?
What do you see on the face? Yes.
It can be like a facial palsy signs like deviation of the mouth
First
to
is
the right or
facial
left.
palsy. Second is visual fields.
Visual homonymous hemianopia.
And third is speech assessment. So you can mention that I would also like to check the patient's speech assessment and visual fields for homonymous hemianopia.
All
Okay,
right.
now I will stop over here. I will jump on to DD's investigation and treatment, and then I will come back to facial weakness, visual fields, speech, and territory for stroke. Because that would be a very long explanation. It can get boring for us. So let's jump onto the points for DDs first. So what are the DDs for this scenario?
I would like to look for the age of the patient. But for this patient, I've had a couple of differential diagnoses. That is cerebral stroke. It could be ischemic or hemorrhagic. It can be a thromboembolic. Then vasculitis can be one of the causes. A dissection, carotid artery dissection can be one of the causes too. And then it could be, if it is a chronic, then I would put multiple sclerosis too. But since the patient, if it's a female and a young age, so I will put the multiple sclerosis as well. It can be a thromboembolic cause, as you told just that it could be any source like a foramen in a vein or a mitral stenosis. So called,
Okay. So
these are a
let's
couple of
just put it in an easier steps. So we can tell the examiner that it depends upon the presentation of the patient. So if
All right.
there's an acute onset, then there are two differential diagnoses. First, vascular event, that is ischemic or hemorrhagic. So we are talking about stroke here. Okay. Second,
Okay.
severe hypoglycemia. So we must check blood sugars on the bedside when we are receiving this patient in our ward. Because when there is severe hypoglycemia, it can mimic stroke.
Yes, sure.
Okay. So I will
Okay.
just repeat that it depends on the presentation of our case. If it's an acute onset, there are two Ds, stroke and hypoglycemia. I would like to check the blood sugars of this patient on the bedside to rule out severe hypoglycemia that can mimic stroke. Okay, and if there is a chronic case, then our differential diagnosis would be first, stroke. It could be that it was a case of stroke and now it's coming in your exams.
All right.
And it's presenting with right or left weakness. First, stroke. Second, a space-occupying lesion. Either it could be primary or metastasis. And third, demyelination. For example, multiple sclerosis. That can also cause this sort of upper motor neuron weakness. It's one of the features of this disease.
Okay.
So let's jump on to investigations. How are you going to investigate this patient?
I will start with the basic blood investigations. It will include the CBC to look for any anemia of the chronic disorder. In that case, it can the mean corpuscular volume might be high or low in cases of iron deficiency anemia. I will also look for ESR-CRP to look for any underlying cause like infection or inflammation, fasting blood glucose, and glycosylated hemoglobins. Then I will also like to check the lipid profile for that will include the cholesterol levels for this patient, as it can be one of the causes for stroke. Uh, Apart from this, I would also like to check the 12 lead ECG, echocardiography, chest X-ray might be, and carotid Dopplers if in case I'm suspecting any dissection. Then investigation will to look for the specifically for this specifically for the stroke. If a patient is coming in acute setting, then I will go for a contrast for a CT or an MRI. In that case, I will look for a CT scan basically to for this patient particularly, and apart from that, I would also like to check the Doppler ultrasound of the neck, and I think
Yes.
is it, or am I
Yes.
forgetting?
Yes,
Okay.
I'm just going to list out the investigations and then you can see if you missed out one or two. So we will start with CT scan first. This is the first investigation that helps to rule out if there is an infarct or bleed. And then blood tests. For blood tests, we have fasting glucose and lipid profile, bedside ECG for atrial fibrillation, and we have got very important investigations to look for the source of thromboembolism if this patient especially had risk factors for atherosclerosis. So I have mentioned ECG for atrial fibrillation, echocardiography. It will help us to see if there was a valve defect or an intracardiac thrombus, and carotid Dopplers. This will help us to look for carotid stenosis. And if it's a young patient, then we can also do a clotting profile or vasculitis screen. That could be one of the causes of stroke in this age group. So when we are doing a vasculitis screen, we will also mention full blood count for a reduced hemoglobin due to a chronic illness. ESR-CRP, inflammatory markers are raised due to inflammatory diseases. And for vasculitis, we have got autoimmune profile like ANCA. So this depends upon the history of our case. But the main investigations are listed out first, that is CT head with bloods. Now, how are you going to manage this patient if it is a case of stroke?
Right. If the patient is coming in the acute settings, like if he's coming in within 4 hours window period, then an urgent CT scan and urgent referral of the to the neurologist. Then CT scan, it will depend upon the CT scan's result. So if it will be a thrombus and ischemic infarct, then it will be the patient would be medically treated with a thrombolytic agents. That will depend upon the neurologist will decide. And then if it's after excluding the hemorrhage, then we are going to start the patient on aspirin, starting with the 300 mg starting dose, and then we can later on shift starting the patient on statin within 48 hours. And then managing the underlying complications like in case diabetes mellitus, hypertension, lipid profile, and patient education and counseling involving of the stroke specialist teams, specialist nurses, physical therapy and occupational health therapist if needed. And
Yes. So this literally covers the whole uh, package of management for a patient of stroke. That first we have to see what was the time of presentation of this patient. So if he presented within 4.5 hours of the onset of symptoms, then this is the window period during which thrombolysis can be carried out after ruling out its contraindication. And that's why we must do CT head first to rule out a bleed. And this is done with TPA.
okay.
Then if this patient has presented out of the window period, then we have got a different plan. So we are giving a loading dose of the antiplatelet therapy, that is aspirin, 300 milligrams per oral stat, and then we give a daily dose. Plus, we refer this patient to the specialist unit where there is a multidisciplinary team approach for a management, and that includes physiotherapy. Its purpose is to teach exercises to the patient to strengthen the muscles. Occupational therapy, it could be done later as well, as this refers to the adaptations which are done in home or the workplace for this patient who will need aids or equipments later. And this will improve their ability to cope with their daily life after a stroke. So the OTs and PTs just come up to the ward to see the patient and then they start their planning for the aftercare. We have got speech and language therapists. When patients suffer stroke, it can affect their speech if the face is affected, and then they're helping with that. And we have specialist nurses, plus DVT prophylaxis. This should be done because the patient is bedridden.
Okay, all right, yeah.
This should be done in the ward. Plus, we have to manage the risk factors like if there is hypertension, blood pressure control. If there's diabetes, we are involving the specialist team for the diabetes mellitus to review it. So we are maintaining the blood sugars, statin therapy, and smoking cessation, dietary advice. So this is started with education and counseling within the ward until the patient goes home, and then this is done. This is reinforced on follow-ups. Now we have to treat the etiology, specific treatment. So if this patient has got atrial fibrillation and this was the cause for the stroke, then this patient needs anticoagulation.
Yeah,
Yes.
yes.
So when will you start it?
After ruling out the other causes, like if there is any underlying hemorrhage,
Yes.
so we can start the thrombolytic, like anticoagulation therapy for this
Yes.
patient.
So that is, for example, if you're starting the patient on warfarin, then that would be 2 weeks after the stroke. The patient will be taking aspirin or clopidogrel, and then we start the patient on warfarin 2 weeks later with INR monitoring, and we also monitor the patient for signs of bleeding. Second, if the cause was carotid stenosis and it's detected on the Doppler scan, and if it is equal or above 70%, then this patient will be referred to the vascular surgeons for carotid and arterectomy. And we have to remember that it is the internal carotid artery that is ipsilateral to the side of the lesion. If it is stenosed due to vasculitis or atherosclerotic plaques, then that is causing the stroke. So here we have touched the etiology. So this is the whole package of management for the patients of stroke. I hope it was clear. Now I will go back to the explanation for weakness of face and speech assessment. So thank you for your participation in the case.
Thank
And
you,
now
Dr.
I'm
Poo.
going to just
Thank you for
deliver the
letting me.
generic description. You're welcome to join the session. So face, if this patient had weakness of the face along with the hemiparesis, then we have to find out the level of the lesion. Now there are two scenarios, or I can call it two variants for this scenario. First, you see that this patient has got, for example, this look. I'm just going to share an image so that it can be explained more nicely. Here I've got this image first. I hope everybody can see it clearly. And if anybody can't see it, then they can let me know. So here you can see that we have a gentleman whose face shows weak. Okay, I'm just going to... It's not clear. Okay, I'll try to upload again. And I'm also going to describe this image so that it is clear. So we have got this image in which a gentleman is showing weakness of the face on one side, okay? It could be left or right in our cases. So if you see here, then half of the face is spared. This gentleman is able to frown. We can see the lines in the forehead, but the face is weak in its lower part. There is a drooping of the lip along, and plus we can see there is a flattening of the nasolabial fold. So if you see the innervation, then the blue nerves are corresponding to a place that is we have the supranuclear lesion over here. So this is upper motor neuron weakness. It is above the level of the brain stem. The nucleus of the facial nerve is embedded within the brain stem, but this lesion is above the level of the brain stem within the cerebral cortex, and this forehead will be spared in this case due to its dual innervation, because it is getting fibers which are sparing it. So when we have this kind of lesion, we will see that it is uncrossed, which means that, for example, there is right-sided upper motor neuron facial weakness, in which we can see that the forehead has got the wrinkles, but half of the face is weak. It is showing weakness in the lower part, with flattening of the nasolabial fold and the drooping of the lip. And there is right-sided weakness in the arm plus minus leg. So this is uncrossed weakness. If this is the case, then the lesion is above the level of the brainstem. It could be cerebral cortex, or corona radiata, or internal capsule. If it is not clear, I will repeat it. Because
please repeat it,
please. Okay, I will repeat it. So yes, it is a bit complicated to understand it. That's why I tried to put an image for it. So you can see that we have, whenever we have upper motor neuron facial weakness on the right or left side, then we will see that the forehead is spared. It is wrinkled. The patient is able to frown, but the lower part of the face is weak. So we can say that half of the face is weak. The lip is drooped. It is dripping down on the affected side. And here, if we get this kind of a look, this is upper motor neuron facial weakness. When we are calling it upper motor neuron lesion, it means that this is above the level of the brainstem. That is the brain areas of cerebral cortex, internal capsule, or corona radiata. So if the lesion is above the level of the brainstem, then the facial weakness will be of upper motor neuron pattern, in which half of the face is spared. And this will be coinciding with the side of lesion. That is, if it is right facial weakness, upper motor neuron pattern, there will be right-sided weakness in the arm and leg. If it is left-sided upper motor neuron pattern of facial weakness, there will be left-sided weakness in the arm and leg. So it will be a weakness which is seen on is seen in just one side of the body. Yes, when the lower part of the face is weak, but the forehead is paired, then it is upper motor neuron facial weakness. This is the whole point. Now, let's take the example of a case in which there is right-sided upper motor neuron pattern of facial weakness with right-sided weakness in arm and leg. Yes, same. All on one side. That is the weakness. It's just seen on the right side. Where is the lesion in the brain? It is contralateral. Yes, it is an uncrossed hemiparesis because the weakness is all on one side, right or left. Okay. So in that case, the lesion within the brain will be on the contralateral side, that is left side for our example. You can also see this diagram that in this case, see the face and see the side of the brain. The lesion is on the opposite side. So you can be asked in the viva when you're presenting to the examiner that where is the lesion in this case? Because you can get a patient who has got hemiparesis with a facial weakness, right or left side. So if it is clear, I will move on to the next image.
Clear.
Okay, so let's move on to the next image. Here we have got a patient with a different kind of facial weakness, this one. Now, this is a lower motor neuron pattern of facial weakness. So now you can see this gentleman that he is very sad on one side. There's inability to wrinkle the brows. We can't see lines in the forehead. It's totally flat. There's a drooping of the eyelid with inability to close the eyes. When you check the cranial nerve 7, there's inability to puff out the cheeks, asymmetrical smile, the lip is down on one side, so you can see the corner of the mouth. So when all of the face is weak on one side, then this is lower motor neuron pattern of facial weakness. And if this is the case, then you will always see that the weakness in the arm and leg is on the opposite side. For example, if this patient had right-sided low motor neuron facial weakness, then he will present with left-sided weakness in the arm plus minus leg. So it's going to be crossed hemiparesis. And when we are talking about a crossed hemiparesis, the lesion is at the level of the brainstem, within the nucleus of the cranial nerve, because it is affecting it. So this is enough for us to remember that if there is a low motor neuron facial weakness of one side, then we will see contralateral weakness in the arm and leg. So the level, it is crossed hemiparesis, and the level of lesion is on the brainstem. For example, if our patient had right-sided facial weakness with lower motor neuron pattern and left-sided hemiparesis with the upper and lower limb, then it is a case of crossed hemiparesis. It means that my patient has got a lesion at the level of the brainstem. So this was the whole discussion for the facial weakness, and it can come in a case of stroke.
Doctor, my question is that, have you finished, doctor?
Yes, I have finished.
Okay, the thing is that how could be the lower motor neuron lesion? It would be the affected the brain stem. If it is something in a brain stem or in a CNS or at this level of the spinal cord, it is upper motor.
Yes, this is a very good point, because when the lesion is in the brainstem, okay, or for the facial nerve, then it affects those fibers of the facial nerve which are controlling the 4 functions on this side of the face.
Doctor, it is a trigeminal actually. I think you are missing something. Can you please check again?
It's a facial nerve.
But facial nerve, whenever the lower motor neuron lesion, it is not affecting the brain stem because nuclei are in the.
Don't dare to come here.
No, dear, it's not like that. Sometimes in the cranial lesion, also we have the lower motor presentation. It's correct. Actually, in pons, the lesion also is like that.
Yes, when we're talking about trigeminal nerve, then it is a sensory nerve for the face. But the motor nerve for the face is the facial nerve. And if it is affected due to stroke at the level of the brainstem, then this causes a lower motor neuron weakness. That is unilateral weakness of the face on the whole one side, in which you will see all these 4 problems that are listed out in this picture. And the main sign is that the forehead will be flat. The patient will not show lines on this side. There is an inability to wrinkle the brow.
May I contribute something? In upper motor neuron lesion of the facial nerve, the forehead is spared because it has a dual supply. It gets nerve supply from both sides of the brain.
Yes, there is a dual innervation.
Yeah.
Yes. That's why the forehead is spared when the level of lesion is above the brainstem.
And the picture was very clear, Dr. Javeria. Thank you for the previous picture.
Yes, so just you're welcome for that. So I'm just going to repeat the points to remember, that if you see that there is upper motor neuron pattern of weakness, plus, I will give it with an example on right side, plus right-sided hemiparesis of the upper and lower limb. It is a uncrossed hemiparesis, and which indicates that the level of lesion is above the brainstem, and it is on the opposite side of the brain, that is the left side of the brain has suffered the stroke. And if we see right-sided lower motor neuron pattern of facial weakness with left-sided hemiparesis of upper and lower limb, this is crossed hemiparesis. That indicates that the level of lesion is in the brainstem. So this is the whole point. Now I was coming to speech because if you come across a curious examiner who wants to ask about speech, then you can just learn 1 or 2 points about speech assessment. So we know that we have got dysphasia in patients of stroke. It can occur in a case a patient who has suffered that. Can I remove this image if everybody has taken a screenshot, or because I want to share this image? Yes. So you can see here Broca's area. So Broca's area is a part of the frontal lobe, and this is the area which controls the expressive speech. It means that when we are trying to say anything, then we are able to articulate it properly. This is the area to control this function, Broca's area. And Wernicke's area is, you can see, I think it's the temporal lobe. So here is the point for receptive speech, then that we can understand the command. And that's why we are answering it sensibly. So if anybody asks you, how will you assess the speech? Then you can divide it into 2 parts. That I can assess the speech in 2 steps. First, I will check the understanding of the patient, or I will check if the patient is able to understand my command. For example, I will ask, can you close your eyes? Or can you hold your right ear? Can you hold this pen? Can you unbutton your shirt? So here, your patient is able to understand the command, and we have checked the comprehension. And this is the function of Wernicke's area. If the patient is not able to do that, it means that there is a receptive dysphasia. The patient is not able to receive the command properly. They're not able to understand it. So the lesion is in the Wernicke's area. Second, step 2, I will see if the patient is able to formulate the speech properly. For example, we can ask very simple questions. What is your name? What is this place? What did you eat in the breakfast today? What is the color of this pen? We just want to see if the patient can speak or there is slurring of the speech. They are not able to articulate it properly. So if this is the case, then it is expressive dysphasia. They're not able to express their point. So in this case, the lesion is in the Broca's area. So I'm just going to summarize it for you. Receptive dysphasia, Wernicke's area. Expressive dysphasia, Broca's area. How are you going to check the understanding of the patient for receptive dysphasia? We will ask the patient very simple commands. For example, can you close your eyes? You can ask one of them. Can you hold your left ear? Can you touch the tip of your nose? Can you hold this pen? And expressive dysphasia, we will see if the patient can formulate the speech properly. What did you eat today? What is this place? What is the color of this pen? What are you wearing today? Yes, so this finishes the discussion of stroke. And now I will welcome the candidates for questions if anything was not clear.
Lesion in the spinal cord, what will do?
I'm sorry?
If the lesion is in the spinal cord, what will be?
So if the lesion is in the spinal cord, then here we will have cases with I think spastic paraparesis. If I'm not clear over it, I think we can ask Dr. Hoda, because when it is the cord, then we have got very different presentations with it.
Yes,
And
doctor,
this is covered within spastic
doctor, this will be a brown squat syndrome.
Yeah, because when we have spinal cord lesions, then we have got very different scenarios. We will
Yes.
see either it is motor weakness with normal sensation, or it is motor weakness with sensation affected. If the sensation is affected, then which modality is affected? Is it the lateral track or is it the dorsal column? So that is a totally different scenario, and we will cover neurological cases next time. And I will explain the spinal cord lesions in those classes. Is that okay?
Okay.
All right. So I hope it was all clear. And if you get a case with lower limb examination, then this is the similar pattern for examination steps. You're going to check tone, power, reflexes, coordination, sensations, plus we will not forget about ankle clonus and planters. And the gait with inspection. You have to see the surroundings of the patient. You have to give the look, just see the hands or forearm. It must be internally rotated if the upper limb is affected with it, and see the lower limb on the right or left side. It will be externally rotated. And then you can start with your examination. The examination steps are done. The DD's investigation and management plan is the same. So I hope it was all clear. And this finishes the discussion for stroke today.
Sorry to ask you, can be stroke only presented with abnormal sensation or loss of sensation only without motor affection?
Well, I think it's not common to see it, but it depends on the site of the lesion, because motor tracks are often involved whenever
Ma'am,
when there is a stroke. Yeah.
in cases of thalamic infarct, that could be a possibility, but I don't think so. Those people will keep those things in PACES exams per se.
Yes, because PACES
Thalamic
wise,
infarct can present with these, yes.
But
yes,
With just
it will not
sensory
be a
abnormalities.
PACES case. So it will be not be a PACES case, and you should
Exactly.
not think of like that. Okay.
Exactly.
Yeah, PACES wise, you will get a very clear case, and they just want to see that you have finished the steps in time, you have not missed a point, that is tone, power, reflexes, coordination, sensations, and you are considering the bedside examination. Either you can go for it or you can verbalize it for the examiner. The pulse, heart sounds, carotid pulse, blood pressure. You can also mention visual fields and even plus speech. Yes, if you're talking about the visual fields, we are looking for homonymous hemianopia, and it will be opposite to the site of lesion. Like if your brain has got lesion on the right side, it will be left-sided homonymous hemianopia. And this also brings us to the territory of the infarct. Like if it is a very tricky kind of examiner, he might ask you about the territory of the infarct. And if we talk about that, we have got the Bamford classification, BAMFORD. I'll write it down, Bamford. I don't have space over here. So Bamford classification gives us 2 or 3 things. It is TACS, PACS, and LACS. I'll write it for you. We have got a very weak pen. TACS is total anterior cerebral circulation. TACS. For example, the middle cerebral artery. This is the most common artery to be affected in stroke. Like if you see this all part of the brain, which is in this picture, middle cerebral artery is in a place over here. So total anterior circulation stroke. So when you have total anterior circulation stroke or TACS, you can find 3 things. One will be hemiplegia, that is contralateral to the site of the lesion. Hemiplegia, homonymous hemianopia, also contralateral. And then higher cortical functions are disturbed, one of which is dysphasia. So I will repeat for you. TACS is total anterior circulation stroke. If you have got this problem in your patient, you can find 3 things. One is contralateral hemiplegia. Second, contralateral homonymous hemianopia. And third is the higher cortical functions will show loss of function or will show disability. For example, dysphasia. And we just talked about that. Receptive or expressive, or it could be both of them. So this is TACS. So this is a very major kind of a stroke. I will repeat it for the doctors who could not get this point. So when there is total anterior circulation stroke, there are three signs of it, okay? First is hemiplegia. We will see weakness of one side of the body, right or left, contralateral to the site of lesion in the brain, hemiplegia. Second, we will see homonymous hemianopia, like when we check the visual fields in this patient's eyes, we will see contralateral side of homonymous hemianopia. That is a defect in the visual field. Third, the higher cortical functions will be disturbed. For example, we can see dysphasia. Dysphasia, it is affecting the speech of the patient. It could be receptive or expressive, or it could be both of it. That is, the patient is not able to understand the command, that is receptive, or the patient is not able to articulate the words, that is expressive. Okay, second is PACS. PACS is partial anterior circulation stroke. Yes, it is contralateral. Contralateral hemiplegia, contralateral homonymous hemianopia. Third, higher cortical functions are disturbed. For example, dysphasia. We can just remember that. Well, we will not have those kinds of questions commonly, but the examiners can ask you about the territory of stroke. So PACS. PACS is partial anterior circulation stroke. So here you will have 2 out of 3. Yes, Dr. Ahmed just mentioned about hemianesthesia. So the higher cortical functions are various things which are, it can get very complicated. There are various functions which include sensation and motor. So one of which is the dysphasia. Now we have partial anterior circulation stroke. So if this is the case, you will see 2 out of 3. 3 of what? Hemiplegia, homonymous hemianopia, and cortical functions, HHC. Okay, so you will see 2 out of the 3 functions are affected due to this kind of stroke. That's why we are calling it partial, because a part of it is affected. And third is lacunar, lax. Lacunar is minor stroke. A small area is affected. Lacunar stroke. It is called lax. So either there is a like a motor loss or a sensory loss. That is pure. It's a pure motor loss or it is a pure sensory loss. But most commonly, you will get a case with cerebral circulation that is affected. And in most common artery in stroke is middle cerebral artery, MCA territory. Yes.
What about posterior circulation?
I'm sorry?
What about posterior circulation?
Yes, for posterior circulation, there is hemisensory loss, in my knowledge. If I'm wrong, one of you can correct me, because one of the doctors just mentioned in the chat box that if we have middle cerebral artery, then we will have upper limbs affected more compared to the lower limbs, MCA. And then we have anterior cerebral artery. In this case, the lower limbs are affected more compared to the upper limbs. And if it is the posterior circulation, posterior cerebral artery, then there is a hemisensory loss. So this is, I'm aware of this set of category for strokes. But if you just know about the Bamford classification, it's a good point to remember for VIVA. Total anterior circulation stroke, TACS, partial anterior circulation stroke, PACS, and lacunar stroke, LACS. And for TACS, you have 3 things: hemiplegia, that's contralateral; homonymous hemianopia, that's contralateral; and cortical dysfunction, in which the higher cortical functions are disturbed. And cortical signs, you can call it PACS. 2 out of the 3 will be affected in PACS. And for LACS, it is a pure hemimotor or sensory loss for the LACS. But LACS is not very common, okay? So you just have to remember the classification. That's enough for you. Pieces wise. Because if we go into more detail, then it becomes a very specialist kind of details, specialist kind of point. So they don't expect that in PACES by you. They just want to see that you've got an idea. I hope it was all clear. This finishes my discussion. It was very long. I hope it did not get boring. Dr. Huda, if you have to add any point?
No, I think you did, you explained everything, okay, very well.
Okay, I think we can wind up now, or because we have answered the questions in the chat box. Yeah, but if there are any more questions, you can write it in the WhatsApp group. Okay, LACS. LACS, it is said that for lacunar strokes, it is a pure hemimotor or sensory loss. If we see it in the textbooks. Yeah.
And
but they will not go into a lot of details with you.
Yes.
So you shouldn't worry about it. So it's just for the purpose of knowledge.
And a stroke is so common in cases that out of 2, 1 will get a case. Or out of 3 candidate, 1 will definitely going to get a stroke case.
Because they are going to mark you on your examination technique, patient welfare, your differential diagnosis, and clinical judgment, and clinical signs. They want to see if you picked it up. And when you're talking about the clinical judgment, then it includes the investigation and treatment plan. So this is enough for the preparation of a case in PACES.
And it's a PACES wise, you can say it's an autosomal dominant condition. Why? Because 50% of the candidate will get this case.
Yes, because it's very common. Yes,
Yes.
every
Or
hospital
at
has
least
got stroke
autosomal
cases.
recessive 100%. Means
Yeah,
out of
yeah.
25% will get this case.
Yeah, so if you see a case of a stroke in your wards,
Hmm.
you can go for the bedside examination, see the signs, and present it to your colleagues. Okay, so I will wind up now. Thank you for attending the session.
Thank you so much, Dr. Javeria, for your session.
You're welcome, sir.
Yes, we all learn a lot from you. Thank you so much. We'll end our session today, and we'll have a communication station, and we'll also request Dr. Javeria to do the session in coming days. Okay, so we'll have a session in coming weeks. Thank you so much, everyone, for joining our session today.